So, doctors, topic of our today's lecture is space gain in orthodontics. What methods of gaining space in the permanent dentition are in orthodontics? Common methods of gaining space are arc expansion and interproximal reduction and molar distalization, or selective or therapeutic extractions. And step by step. First way, arc expansion. The upper arc is well suited for expansion than its lower counterpart. Usually done in narrow contracted upper arches with cross bites in the premolar region. What do you know? What do you need to know about expansion of dental arches? Expansion is a method of gaining space. Correction of transverse, maxillary, and of course mandibular deficiency. First achieved by Emerson, Cullen, Angel in 1860. This dentist is known as the father of the rapid maxillary expansion. He published a paper in Dental Cosmo Journal in 1860 in which he described this technique. Numerous factors influence this, including age, growth, potential, amount of force, and even sex of the patient. And now let's talk about expansion classification. There are two main classifications about types of expansion. First of them is classification based on the types of expansion. According to types of expansion, the orthodontic, orthopedic, and passive expansion. And classification of expansion based on the rate of expansion. Expansion and slow expansion. Moreover, they are divided into orthodontic or dental expansion. It is results. Now more detail about types of expansion. Orthodontic or dental expansion. It results in lateral movement of buccal segments that primarily are dentoalveolar. For example, finger spring appliance, like shown on this picture. Orthopedic or skeletal expansion. Here the changes are produced primarily in the skeletal structures rather than by the movement of teeth through alveolar bone. For example, a rapid maxillary expansion. and passive expansion, when the forces of buccal and lingual musculature are shielded from occlusion. A widening of dental arches often occur, which occur due to the intrinsic forces such as tongue. Like example, they are shown removable orthodontic appliance, Frankel appliance, second type. Or like example can be lip bumper therapy. Lip bumper, it is this device. And what indications for maxillary expansion? First of all, of course, cross bites, mild crowding, expansion along with functional appliance treatment, skeletal class 3 malocclusion, distal molar movement, or surgical orthodontics. Let's mention about applied anatomy. As you know, maxilla together with the palatine bone forms the hard palate, floor, and greater part of the lateral walls of the nasal cavity. Most of the sutural attachments of the maxilla to the adjoining bones, frontal, ethmoid, nasal, lacrimal, vomer, zygomatic and palatine, aerate its posterior and superior aspects, leaving the anterior and inferior aspects free, which make it vulnerable for lateral displacement. And now let's talk more detail about different ways in expansion of upper dental row. The most widespread, it is a rapid maxillary expansion, or abbreviation RME, also called rapid palatal expansion or split palate. Definition of what is this? It is a skeletal type of expansion that involves the separation of the mid-palatal suture and movement of the maxillary shelves away from each other. Emerson Angel is considered as the father of rapid maxillary expansion. I gave you this information earlier, and it was in 18th century. Rapid maxillary expansion should be initiated prior to the ossification of the mid-palatal suture. Transverse growth of the mid-palatal suture continued up to 16 years in girls and 18 years in boys, according Melson information. The sphenoid and the zygomatic bones have a buttressing effect resisting mid-palatal suture opening. What stages of mid-palatal suture formation we know? First stage, when this suture is not ingrown, and in this area are present active osteoblasts activity. First stage or infancy. Second stage, or childhood. Osteoclasts are active, but shape of the suture not straight, but curved. And third stage, early adolescence. Activity of osteoblasts is decreased, and shape of this suture, as can you see, is so much curved. What indications of a rapid maxillary expansion? First of all, it is posterior crossbite associated with real or relative maxillary deficiencies. Third-class malocclusion of dental or skeletal cause. Cleft palate patients with collapsed maxillary arc. In patients requiring face mask therapy. And medical indications like sleep apnea. What effects of rapid maxillary expansion we know? First effect, it is maxillary skeletal effect. Second one, effect on maxillary anterior teeth. Third one, effect on maxillary posterior teeth. Next one, effect on mandible, effect on adjacent cranial bones and sutures, and effect on rapid maxillary expansion on nasal cavity. Nasal breathing improves after this procedure. And what types of rapid maxillary expansion appliance are used in modern orthodontics? It can be a removable appliance, consists of a split acrylic plate with a midline screw. Except of removable appliance, they are used fixed appliance. And fixed appliances are divided into tooth bone, the Hyrax type, Isaacsson type, McNamara type appliance, Fun type appliance. This kind of appliance increase transversal dimensions of upper dental row only in premolar region, but not increase it between molars. And tooth and soft tissue bone. There is Weiler type, it is a fully acrylic appliance. Premolar and molar bands are not connected with screw by metal, only by acrylic. And Haas type. This appliance is similar to Hyrax type, but Haas added some acrylic for additional pressure, not only on a tooth, but on a teeth, but on a mucous membrane of palate surface too. Haas type. Now I would like to present you short animation about Hyrax appliance. There shown a special key for opening Hyrax screw, and after a few weeks posterior crossbite will be eliminated. And of course then we need to use brackets to finish our treatment. They are shown distal crossbite. Let's look at once again. As usual, activating of the screw is 1 per day. Or another kind of Hyrax appliance, bonded Hyrax appliance. The similar situation, posterior cross bite, but in case of frontal deep bite, to increase vertical dimensions, we can use bonded Hyrax appliance. Tooth and soft tissue borne, and tooth and bone borne, like hybrid Hyrax type of appliance. They are shown this kind of appliance. As can you see, this Hyrax, this hybrid Hyrax type of rapid maxillary expander is fixing to the molars and to the orthodontic mini screws. And only bone borne. This kind of appliance is called quad Hyrax. Why quad? Because they're using 4 orthodontic micro implants, or tandem skeletal expander, like quad Hyrax but with 2 screws. How can we evaluate effectiveness of our treatment? First of all, they appear diastema after near 2 weeks of appliance activation. Before activation and after Hyrax activation. We can conduct maxillary occlusal radiography, and we will see opened middle palatal suture or posterior anterior cephalogram. But for rapid maxillary expansion, there are a few contraindications. First of all, it is single tooth crossbite. What does it mean? It means that transverse dimensions of dental row is normal, but only one tooth is in crossbite position. It is not indication to expand transversally all dental row. In uncooperative patient, it is universal contraindication, maybe for all orthodontic treatment and maybe for all dental treatment. After ossification of mid-palatal suture, unless accompanied by surgical procedure. Skeletal asymmetry of maxilla and mandible and severe anterior-posterior skeletal discrepancies. We are not gods and we cannot do everything like orthodontists. To get ideal result for this patient, we need to cooperate with surgeon. Vertical growers with steep mandibular plane angle. Why? Because after mid-palatal expansion, anterior open bite will open more. And of course, in periodontal wig dentition, and of course, anterior open bite. And after a rapid maxillary expansion, we need to stabilize our result this period is called retention. How can we get retention of our results? And what features of this retention? First of all, retention after a rapid maxillary expansion must be from 3 to 6 months. And we can use Isaacson method. Isaacson used rapid maxillary expander itself like a retainer. But to prevent relapse, we need immobilize this screw by some cement or some composite or some acrylic. Alternatively, either a removable or fixed retainer, for example, transpalatal arc, can be used. As can you understand? This kind of appliance is more convenient for patient. And next type of maxillary expansion is slow maxillary expansion. And what kind of appliance I used for this type of expansion? First of all, it is quad helix. Why quad? Because quadro, 4 loops, and this kind of appliance can be manufactured by dental technician in dental laboratory or by doctor himself. In case of laboratory manufacturing, this wire must be welded to the metal bands. But in case of doctor's manufacturing, we can use standard molar bands with special pre-welded slots. Titanium expander. It is the most likely expander. Middle part of it is manufactured from nickel titanium alloy. Why I like this kind of appliance? Because it doesn't take so much time to introduce it or to remove it. But doctor must have a full set of sizes. Or W arc. Why W? Because this arc is like W letter. And now let's talk more detail about slow maxillary expansion appliances. Quad helix. The shown process of quad helix manufacturing. As for me, it is the best video. I analyzed so much videos and chose this one for you. I hope you know Spanish. understand, dental technician is welded hot helix to stainless steel molar bands. Then remove from gypsum model. Cleaning and polishing. Cleaning and polishing box. and activation with three finger pliers. The shown effect of activation in separated model. We can ask dental technician manufacture additional element for frontal teeth. Once again, doctors, it is the best video about quad helix I found, and they are shown different types of quad. Now short animation about titanium expander, sorry. We need choose size more than distance between molars. And insert it into a palatal slot. And animation about W arc. They're shown distal cross bite, the visible narrowing of dental arc in premolar area. And doctors, you need to know about surgery as an adjunct surgically assisted rapid palatal expansion, abbreviation SARPE. Patients who exhibit unusual resistance to separation of the palatal bone or whom the mid-palatal suture has ossified require surgical intervention. It may also be required in patients exhibiting increased circummaxillary rigidity as a result of aging. The surgical procedures carried out are palatal osteotomy. It is surgical intervention into mid-palatal suture. Lateral maxillary osteotomy. Anterior maxillary osteotomy. It is the least stable orthodontic surgical procedure, as it causes widening of the maxilla, stretches the palatal mucus, and its elastic rebound is the major cause for relapse. And now let's talk about slow expansion. This technique is a more physiological adjustment to maxillary expansion. It has greater stability and less relapse potential than rapid expansion procedures. The maxillary arc is expanded at a rate of 0.5 to 1 millimeter per week. The force generated is about 2 to 4 pounds. It makes as much as 2 to 5 months, followed by retention. Here no midline diastema occurs. And the interesting table, a comparison between slow and rapid expansion. If we talk if we see at features, slow expansion has mostly dental effect, or type expansion. Rapid expansion has skeletal influence. A rate of expansion, slow of course, and rapid, type of tissue reaction. Slow expansion has mostly physiologic tissue reaction, but rapid expansion more traumatic. Forces used for slow expansion are milder forces, but for rapid expansion, greater forces. The differences between frequency of activation. In case of slow maxillary expansion, we need less frequent, but for rapid expansion, more frequent. And of course, the difference between duration of treatment. Slow expansion is longer, but rapid expansion is shorter. Type of appliance we use. In case of slow expansion, we use either fixed or removable, but in case of rapid expansion, mostly fixed appliances. Slow expansion we can propose for our patients in any age, but rapid expansion before fusion of mid-palatal suture. And maybe the most important point, retention. In case of slower expansion, less chance of relapse, but more chance of relapse in case of rapid expansion. Next way of gaining space in dental arches, interproximal reduction, or IPR abbreviation. Interproximal reduction is a procedure to create space for crowding and increase stability by flattering curved contact surfaces. The enamel is removed by using either a fine dental bore or a disc in a dental handpiece drill, or with an abrasive strip, manual or handpiece. What main rules of interproximal reduction? Maximum of 0.5 millimeter interproximal reduction per contact is recommended. or in another words, 0.25 millimeter each side of incisor. Therefore, a total of 2.5 millimeter of tooth size reduction is possible from cuspid to cuspid. And how we need to take decision. Decision to do interproximal reduction is based on the model analysis concerning the overall size discrepancy. And it could also be added up with the Bolton analysis. About Bolton analysis, we talked with us last week. And now, animation about...
Interproximal reduction is a procedure in which small amounts of enamel are removed from the edges of crowded teeth to make room for them to move. When we recommend IPR, the treatment plan for each appointment will show you where to perform it and how much space to create. When you submit a case, you can specify whether you do want IPR, you don't want IPR, or you want us to recommend IPR as needed. Let's take a look at a few examples. 0.1 millimeters IPR of the anterior teeth. Take a medium diamond strip and cut it in half. The other half can be saved for another patient. Hold the diamond strip at each end and slowly saw back and forth from the incisal edge down to the gums. Widen the contact until the diamond strip can easily pass between the teeth, then flip the diamond strip and repeat on the other side. Slide the 0.1 millimeter gauge between the teeth. If it feels too tight, don't force it in. Just continue abrading the contact area with the diamond strip until the gauge fits. 0.2 millimeters IPR of the posterior teeth. You'll need a single-sided diamond disc and a 0.2 millimeter IPR gauge. Make sure your patient's lips and tongue are retracted before you begin. Open space by moving the disc slowly from the incisal edge to the gingival. Confirm that you've completely broken through the contact by gently pushing against the gums after the disc stops spinning. If the gums blanch, you're good. Confirm that the contact is fully open by running floss between the teeth. Then use the 0.2 millimeter IPR gauge to ensure the correct amount of space has been created. 0.3 millimeters IPR of the posterior teeth. You'll need a double-sided diamond disc and a 0.3 millimeter IPR gauge. Begin by sawing down from the incisal facial of the contact. Then gradually move across to the lingual side and finish opening the contact down to the gingival. You can use your pinky to guide the handpiece. Gently nudge the gums with the stationary diamond disc to check for blanching and confirm you've sawed all the way through. Then measure the space created with the 0.3 millimeter IPR gauge.
Please, one video more about stripping. Concern of patient, black triangle between upper central incisors. author is using Flex polishing system discs. Effectiveness, sign of effectiveness is pale gums between central incisors. And I would like doctors to show you a very interesting separating system from Comet company.
Feel the impact. Comet USA introduces the innovative OS system, which was designed for safe interproximal enamel reduction and doesn't require the use of a disc guard. Insert diamond strip using gentle manual separation into non-cutting area. A fine and medium strip might be necessary. The segmented discs are exclusively designed for use in the oscillating Comet Contra-Angle OS30 handpiece. There's a 6mm diamond coating on each disc, which produces excellent grinding efficiency. Engage the handpiece before doing interproximal reduction. Oscillating angle of the discs is 30 degrees, 15 degrees in each direction. Diamond discs are available in single or double-sided with a range of different thicknesses and grits. Using the OS system will result in minimal reduction to tooth structure. There are 8 positions which allow for optimal access in lingual and buccal areas of the mouth. The risk of injuring the soft tissue is virtually eliminated when using OS30. It's more comfortable for the patient and safer. It reduces the risk of gingival injury and results in less time in the chair. Comet's compost system polishers create a perfectly smooth surface. First, use the blue polishing disc, followed by the red one, and finally the white one. Remember to apply fluoride to the enamel to conclude treatment. Enamel can be reduced by the exact amount necessary for aligners and orthodontic procedures. The thickness of the oscillating discs is 0.05 millimeters less than the required dimension. A rotated tooth many times presents a challenge of damaging the adjacent tooth when preparing for veneers or full crowns. As seen here, the OS system allows the practitioner a safety net by using the cutting side of the disc to open the contact, while the non-cutting side protects the adjacent tooth. The simplicity of the OS system allows the practitioner a simple solution performed in less time, providing a precision cut to produce clinical excellence for all patients.
And shortly about gaining space by molar distalization. Appliance types for molar distalization. It can be extraoral appliances like for bilateral molar distalization we can use cervical pull headgear or combi pull headgear. For unilateral molar distalization with unilateral face bows we can use power arm face bow, soldered offset face bow, swivel offset face bow, spring attachment face bow, and intraoral appliances. Intraoral appliances. The Atkinson's buccal bar, tandem joke, 3D biometric distalizing arc, modified Herbst appliance for distalization of molars, Jasper jumper, sliding jig, cricket appliance, intra-arc appliances, sagittal appliance, magnets, modified lingual and nance holding arches, John jig, Night-Eye spring, pendulum appliance, super elastic Night-Eye wire, small distalizing bow, space regainers, K-loop, fixed piston appliance, distal jet, C-space regainer, palatal orthodontic implants, first class appliance, fixed palatal expander, locker molar distillation, transpalatal arc, and many other appliances. As for me, it is topic for separate lecture. Intraoral appliances for molar distillation. And of course, we can gain space by extraction. No body, no problems. No teeth, no problems.